So, my name is Dr. Imran Ahmed, and I'm working as an assistant professor of ophthalmology in Khyber Medical College and Khyber Teaching Hospital. And today we'll discuss the management of the diabetic macular edema and the disease burden, the prevalence of diabetic retinopathy, and specifically in the developing countries. So, I will start with a quote of the George Bernard Shaw that beware of false knowledge because it is more dangerous than ignorance. I would like to pay tribute to my teachers, Professor Ibrar Hussain, Professor Sanaullah Jan, and Professor Muhammad Tariq Khan. Then coming to the prevalence of diabetic retinopathy, uh, actually, it's very much prevalent in the developing countries. One and every four people are diabetics in Pakistan. Actually, a survey was done in 2007. At that time, actually, the total number or the total population of diabetes in Pakistan was about 6.9 millions. And then they projected that actually by 2025, the total population in Pakistan would be 11.6 millions. But you just can imagine that in 2025, 2021, we were actually having more than 33 million of people living with the diabetes. And Pakistan is actually the third country with the highest number of the diabetic patients. And since in the year of 2022, 23, and 24, Pakistan is having the highest prevalence of diabetic patients. So, with increasing and the diabetes, definitely the complications associated with the diabetes will also be increasing. You can see from this figure, actually, this brown color, you can match it over with this one. That is the 26 to 30% of the population in Pakistan are diabetics. And about 31% of the population is diabetic, and it is the highest in the world. Actually, we don't have proper data regarding the diabetic population because of the lack of database. And it's not only the issue of our country, but actually it's the issue of all developing countries. And even nowadays, the developed countries are facing this issue of diabetes. And actually, the disease is increasing. And whenever the disease is increasing, definitely it will be associated with increasing complication of the disease. About around about 27% of the adults in Pakistan still they are living undiagnosed, means they're diabetics, but they don't know that they're diabetics. And that's the reason most of the time when we are examining the patient and we see the patient is having diabetic retinopathy, and when we ask the patient about the diabetic status, the patient is saying that we are not diabetics. And actually, after investigation, the patient came to know that he's diabetic actually for quite long. So that is another dilemma that we are facing. Screening is very much important for the diabetes, and that's actually something that has adopted by the developed world as well. That after screening system that was introduced for the diabetic retinopathy, actually the disease burden has reduced, and the visual loss due to the diabetes that also reduced because it can be prevented by timely diagnosis and treatment. Actually, we are having a opportunistic system. We don't have proper screening system for the diabetic retinopathy. There is a huge burden on the public sector hospitals. A lot of people are visiting the public sector hospitals, and we are having basically most of the developing countries are having the paper-based system. So you cannot trace your patients back like in the developed countries where the database system is there. So our system is basically opportunistic, and anyone who is coming to the outpatient department, whether the patient is diabetic, the patient is hypertensive, the patients with the cataract or any ocular disease, they're coming to the outpatient department and they are screened over there. So in such cases, usually most of the patients are missed. And that's the reason I was looking at a study a few months back that even the patients who were referred to for the screening of diabetic retinopathy actually were not screened because the patient was unaware that for which purpose the patient has been sent to the outpatient department of ophthalmology, and even the examining doctor was not trained enough to see because there is a rush and most of the time the patients are missed. So for the proper screening of the diabetic retinopathy, we need a systematic screening approach. And actually, it is not very much human resources is not needed, because it doesn't need a retinal specialist to be sitting over there. It only needs a good grader, and the grader need to be trained only on the grades of the diabetic retinopathy. Like this patient is having pre-proliferative, mild, moderate, or severe, and only it's the job of basically an optometrist who is trained for the grading of diabetic retinopathy to take a photograph of the fundus and then accordingly to grade it whether the patient needs referral to the retinal surgeon or retinal specialist or not. If the patient is having no diabetic retinopathy or very mild NPDR, then the patient need to be followed again after a year. And again, depending on the severity of retinopathy, then the duration of follow-up can be reduced. So it needs only a fundus camera and the Department of Ophthalmology. Actually, in the developed countries, there is proper database system. Any patient who is diagnosed to be diabetic, that patient is entered into the database, and then at regular interval, the patient is screened, like as the protocols are for the screening of the diabetic retinopathy. That and type 2 diabetics actually at diagnosis, the patient should be screened for the retinopathy, and then depending on the severity of retinopathy, or if there is no retinopathy, then annual follow-up, or if the severity is more than 6 months, 3 months, or monthly, if associated with central volume diabetic macular edema. Secondly, there is call recall system. And if the patient after a specific period of time receive a call from the hospital or automatic message that is going to the patient for the visit again. And specialized diabetic retinopathy clinics are not there in the public sector hospital in the developing countries. Again, it only needs a proper retinal specialist to be sitting in the diabetic clinic. And if the diabetic clinic is available over there, actually the patient will be knowing that I have to come over here, I will be screened here, and the treatment will be advised by this particular person and this clinic. And even the ophthalmologists know that I have to screen the diabetic patients today are in this clinic. So actually, without specialized diabetic clinics, again, it will not be possible by depending on the opportunistic system. This was a study. Actually, I conducted two studies on this one a few years back, and one last year that is published in the Gomal Journal of Medical Sciences, the prevalence of diabetic retinopathy. And you can believe that 72.2% of the patient for the first time they presented to the ophthalmologist were having diabetic retinopathy. For the first time they were screened, and 56.2% were having diabetic macular edema. And these were the patients who presented for the first time. This was the study that we conducted in 2017 and 18, and that the presentation pattern of the patients with the diabetes that presented to us, uh, you can see the over here that is the referral by physician and endocrinologist were around about 20% of the patient were referred by the physician or endocrinologist, whereas the GP referred only around about 4% of the patient for diabetic retinopathy screening. So again, we have to educate the healthcare providers as well, because every patient with the diabetes should be referred for the proper screening, and then it's the job of the ophthalmologist or the retinal specialist that he has to educate the patient that after a specific period of time, the patient need to be followed. These are the awareness level of the patients in our study. You can see that the patient who are not having any awareness about the visual loss due to the diabetes was 75%. Glycemia to be a risk factor for the progression of retinopathy, 68% were not aware. Hypertension, hyperlipidemia, more than 90% of the people were not aware that these are the risk factors. So you can imagine the level of the health education and the developing countries about this disease. Our health resources, most of the developing countries are facing this issue. They're having very meager health resources, and usually because diabetic retinopathy, if we come to the treatment of the for the treatment of retinopathy, actually it's very expensive, because if the patients, let's suppose, develop diabetic macular edema, the patient need to be treated with anti-VEGF, which is the first line treatment nowadays. If the patient is having advanced or proliferative retinopathy, then the patient need to be treated with the lasers, which are not available in every public sector hospital in developing countries. Even if you go more advanced stages, actually, if the patient developed going to the advanced diabetic eye disease or has developed the tractional retinal detachment, definitely the option is the pars plana vitrectomy, so that the resources are not available in the developing countries. And the burden of the disease is huge. Still, we have a hope that we will cope with the situations and hoping for the best. In our study, we also looked for the barriers that why the patients are not coming for the diabetic retinopathy screening. The major issue is the lack of awareness in our population. That is 71% of the patients were unaware that the diabetes can cause visual loss. Then the financial cost, transportation, physical disability, dependency, because these patients are dependent on other people and their home to take them to the hospital, and the facility not available in the nearest hospital, because these facilities are usually for the screening and treatment of diabetic retinopathy is usually available in the large hospitals are the tertiary care hospitals. Now coming to the main talk, that is the diabetic macular edema. Diabetic macular edema is the most common cause of visual loss in the working population, both in developed and developing countries. The mechanism of the diabetic macular edema, actually two main changes take place in the diabetic macular edema. One is the basement membrane thickening, which the diffusion of the oxygenation and the nutrients that is not take place. The second thing is the loss of the pericytes, because pericytes are responsible for the integrity of the small vessels. Whenever there is loss of pericytes, the vessels become leaky. There is outpouching of the vessel wall leading to the microaneurysm formation. These microaneurysms then leak, and there is leakage of the fluid into the interstitial tissue, leading to the macular edema or and to the retinal edema. There is occlusion of the small vessels, there is damage to the endothelial cells, and this occlusion then causes the release of vascular endothelial growth factors. The vascular endothelial growth factors, and again, it causes the loss of the pericytes, and again the vessels become weak, and this is a vicious cycle, and then that it started and then going on and on if the risk factors are the diseases not controlled. Hyperglycemia, it induces the advanced glycation end products along with the PKC, and the oxidative stress is produced. It causes loss of the endothelial cells, that is dysfunction. There is loss of the pericytes. Pericytes, as I already mentioned, that is responsible for the integrity of the small vessels. Then the inflammatory cytokines are released, and the blood-brain barrier breakdown take place, which leads to the leakage of the fluid into the interstitial tissue of the retina, leading to the macular edema and retinal edema. There is overexpression of VGF again, which going and turn the same mechanism, that is again with the passage of time it's increasing, the vascular permeability increases, leakage increases, dysfunctional Muller cells, which leads to the impaired fluid clearance, leading to the retinal edema and macular edema. Coming to the classification of diabetic macular edema, actually there are so many classifications available. This one is basically the ETDRS classification, and the ETs, that is early treatment of diabetic retinopathy study. And this was called the clinically significant macular edema. That is the retinal thickening within 500 microns of the center of the macula, hard exudates within 500 micron of the center of the macula associated with retinal thinning of adjacent area, and retinal thickening of 1 disc diameter, that is 1500 micron or larger, and any part of which lies within 1 disc diameter of the center of the macula. This was the definition of the clinically significant macular edema, because in the 80s when the ETDRS study was done, at that time anti-VEGF were not available, and the treatment for the macular edema was focal laser, and that was again recommended by the ETDRS, that if there is clinically significant macular edema, if these findings are there and we go for the focal laser, that was the name was changed to modified focal laser. And if we do this laser, actually the chances of visual loss is reduced by 50%. And that's why this clinically significant edema, then for about two decades, this terminology was used. Then based on the fundus fluorescein angiography, if there is focal leakage, their focal macular edema will be there. If there is diffuse, there are multiple points of the leakage, then there will be diffuse edema. And the most important one, we have to rule out the ischemic maculopathy, which is very common in diabetic patients. We need to look for the foveal avascular zone. Actually, the foveal avascular zone, the circularity of the foveal avascular zone is important. And also, if there is disintegration of the circularity of foveal avascular zone, it's again, there will be capillary dropouts, and that is the ischemia of the macular region. Because even in diabetic patient, if the patient develop macular ischemia, you cannot treat ischemia. Then, based on the OCT, that is the center involving diabetic macular edema and the non-center involving diabetic macular edema. If the central subfoveal 1000 micron region is involved by the edema, that is basically the central involved diabetic macular edema. Whereas if it is outside that submacular 1000 micron region, then this is the non-center involving diabetic macular edema. Actually, it's very practical classification, and because we are doing the OCT routinely for our patients, so if the center is involved, actually the treatment is based on whether the center of the macula is involved or not. If the center of the macula is involved, the ideal treatment is we have to go for the anti-VEGF injections. If it's a non-center involving diabetic macular edema, then the treatment is laser. Then the other variants of the diabetic macular edema, that is the cystoid macular edema, diffuse area of leakage will be there, leading to diffuse edema. Then if the tractional component is there, definitely the treatment plan then changes, and such patients usually will not respond to your anti-VEGF or steroids, but actually we have to remove the traction, and that will only be possible through pars plana vitrectomy in these patients. Sometimes there is serous elevation of the macular region again. So these are the different variants of the diabetic macular edema on optical coherence tomography. Coming to the sorry, coming to the management of diabetic macular edema, let's suppose the patient comes to you and there is no diabetic macular edema or there is no retinopathy. Actually, this is the stamp I apply to on the pages of all patients of diabetes, that the patient must know about the risk factors. Even if there is no retinopathy, the patient has to be aware about these risk factors, because if the risk factors are not controlled, then the patient will develop diabetic macular edema along with the retinopathy, then leading to the complication of the retinopathy. So because HbA1c level is important and the patient has to keep it below 7, 6 to 7 in diabetic patients, and the anemia is associated with the progression of retinopathy. Lipid profile hyperlipidemia is again associated with the progression of retinopathy, and this hypertension, all these things, actually it was studied in the diabetic control and complication trial DCCT and UKPDS trials, that if we control the hypertension level of the patient, if we control the risk factors, then we decrease the occurrence, decrease the progression of the disease, and also the prevalence of the disease can also be reduced. That is, the diabetic retinopathy can be reduced if we are able to control the risk factors for the progression of disease. When to treat a patient with diabetic macular edema. Let's suppose the patient comes to you with a good vision. Let's suppose the vision of the patient is 6 by 6. You did the OCT of the patient, and there is in the center of the macular region, there is some macular edema. Then whether to treat this patient or not. Actually, if the vision is good, such patient do not need any treatment. The evidence is from the protocol V. Actually, in protocol V, what they did, they treat the patient who are having a visual acuity of 6 by 6 and those patients who are having visual acuity of 6 by 6, treat some patients of those. Some patients were observed and some patient lasers were done. Actually, after 2 years, they came to the conclusion that there is no effect, whether there is no difference in the visual outcome, whether the patients are observed, the patient are given anti-VEGF injections, or the patients with the lasers. So they recommended and concluded that if the vision of the patient is good, there is no need of treatment. And that's the reason that the indication for the anti-VEGF injections for the macular edema is that also stated by the ICU guidelines, that it is 6/9 or worse, not on the vision of 6/6. Better to wait and see the patient of 6 by 6. If the vision is deteriorating, then definitely you have to shift your protocol, and then you have to treat these patients. Center involving diabetic macular edema, as I already mentioned, that if the central subfoveal 1000 micron region, submacular 1000 micron region is involved, then this patient is having centrally involved diabetic macular edema. And the treatment guidelines for this is we have to inject in these patients the anti-VEGF is needed for such patient if the center of the macula is involved. Now, if the and how you will know that the patient is it's within the center, that is by the ETDRS chart, and the center circle is basically 1 millimeter, that is 1000 microns. So any edema within the first circle, the central circle, actually it will show that the edema is within 1000 micron, and the patient will need treatment with anti-VEGF injections. If the patient is having non-center involving diabetic macular edema that is outside the central 1000 micron region, actually these patients then need laser. Focal laser is needed for such patients. But before going for the focal laser, it's very, very much important to go for the fundus fluorescein angiography because of the reason that you will be pinpointing the leaking microaneurysm. Like if you are not going for the fundus fluorescein angiography, it's very difficult to exactly localize from where the leakage is, and then you have to apply laser to that particular region. We know that foveal avascular zone is no-go area, but the macula is also a no-go area without fundus fluorescein angiography. Only exception to this case is only the succinate pattern of maculopathy, because in succinate it's in the circular pattern the edema is, and it's definitely that is leaking from the center, so we need to apply the laser to the center. But for the other areas of macular region, for the macular edema, actually it is must to go for the fundus fluorescein angiography, and without angiography, macular area is the no-go area for the focal laser. Coming to the anti-VEGF, which anti-VEGF we can give? Actually, the first anti-VEGF that was approved by FDA in 2004, that is was picaptenib, that Macugen. But because of its specificity for only one particular type of VEGF, VEGF 165, the picaptenib was targeting. So actually, it was not that much effective. Later on, when the ranibizumab was introduced, actually it was having so many isoforms, and it was acting against so many isoforms, so that the results of ranibizumab were much better than that of picaptenib, and that was replaced by the ranibizumab. And then the ranibizumab got approval in 2012 for the diabetic macular edema and age-related macular degeneration. Ranibizumab is available with the name of Lucentis in developed countries, and with the name of Petizra in developing countries because of their because of some economic reasons, we can say. Actually, the ranibizumab got approval after RISE and RIDE trial. Zero point 0.3 and zero point 0.5 milligram anti-VEGF were compared with the shame, and it showed that ranibizumab is much more effective in comparison to shame in terms of anatomical treatment of the macular edema, and also there was also the visual recovery was very good. Then the Vivid and Vista trial was basically done for the aflibercept, and 2 milligram four weekly were given for first 5 months, followed by the 8 weekly intervals. And it was superior to laser photocoagulation. Vivid and Vista, it was compared with the lasers. So it got approval after that. Then the protocol I, actually, and protocol I, ranibizumab was monotherapy was compared with the ranibizumab plus laser, were and with only laser and with lasers plus steroids. So the protocol I actually showed that the ranibizumab monotherapy is much more effective. The patients and whom the ranibizumab was aided along with the laser, actually the number of injections were less, but overall the effect of monotherapy were better. Then in protocol T, actually the aflibercept, ranibizumab, and bevacizumab was compared in the diabetic patient, that which one is more effective. Actually, all three were effective if the visual loss is mild, that is less than 20/50. But if the visual loss is more than 20/50, then aflibercept was superior to ranibizumab and bevacizumab. The faricimab that was approved by FDA back in 2022, and before faricimab, actually the brolucizumab was introduced, and that got approval in 2022. And the beginning, actually the February or March, they got approval for the age-related macular degeneration. I'm talking about the brolucizumab. And then in September and October, they got approval for the diabetic patient, diabetic macular edema as well. And that is after the Kite and Crystal trial for the brolucizumab that was conducted, and FDA given approval on the basis of that. But and the actually the brolucizumab, the injection duration was 6 weekly, but actually, and the anatomical treatment of the macular edema and also the visual recovery were very good and brolucizumab, but actually that was associated with some serious complications, that is the vitritis, inflammation, and vascular retinal vasculitis that it produced. So because of that, the brolucizumab was not very much popular and banned in so many countries for the intravitreal use. Then the faricimab, again in the same year, that is in 2022, faricimab was approved by FDA after Eucimide and trial, and which there it was compared with the aflibercept, and it shows that it is non-inferior to aflibercept, and the anatomical and visual recovery is better than aflibercept. And then the Boulevard trial was conducted, in which the faricimab was compared with the ranibizumab, and again that trial showed that faricimab is comparatively better than ranibizumab as well. But the world, around about 67% of the population is still dependent on the bevacizumab, which is a non-approved drug, not approved by the FDA, but still it is used for the diabetic macular edema, for the age-related macular degeneration, macular edema due to the vascular occlusion, any type of macular edema. And because in the developing countries, the patients are not affording, and the patient has to buy actually these injections for themselves. So the most of the population, its off-label use is very much common, but there are some serious side effects associated with the bevacizumab. That is the cluster of infections, and that has been reported throughout the world with the bevacizumab. And actually, because then it's very difficult to defend yourself while injecting a non-approved drug. But still, the bevacizumab is very good. That is, and it has been shown by so many trials. That is, the Protocol T have shown that it's equally effective like that of the ranibizumab and aflibercept, and the BOLD trial in which it was compared with the lasers. It also showed that bevacizumab reduces the macular edema, and also the visual improvement is there with the bevacizumab. Sometimes you are injecting one anti-VEGF, but it's not working. So the ROTATE trial actually showed that those patients who were initially given bevacizumab and who were not responding, their macular edema were not responding to bevacizumab, actually they responded to ranibizumab. Some people are not in this favor, and they're saying that if one anti-VEGF is not working, definitely the other anti-VEGF is not going to work. But actually, every anti-VEGF has a different molecular structure and different type of mechanism they are having. So the rotate study actually there then concluded that if one anti-VEGF is not working, then you can change the brand of anti-VEGF, and the other anti-VEGF might work. So if one is not working, you can change the brand, try another anti-VEGF. Still, if there is no response to anti-VEGF you are injecting, you have given 3, 4, 5, 6 injection, but the patient is not responding, then what you need to do, you have to go for the wide field angiography. And on the wide field angiography, you have to look for the non-perfused region, the peripheral ischemia, the avascular area of the retina. Because if there is avascular area of the retina, what this avascular area will do, it's a source of continuous release of vascular endothelial growth factor. Vascular endothelial growth factor in terms makes the small vessels leaky. You will be injecting and injecting, but there will be a recurrence of the macular edema again and again. So you have to go for the wide field angiography to check for the retinal perfusion, and if the retinal perfusion is not there and the particular region, or there are ischemic regions, so the only treatment for the ischemia is to destroy that retina. We have to, because we need to make the hypoxic retina into the anoxic retina, so there is no oxygenation demand for that retina, and when we have to lase that particular area of ischemic retina, and with that the release of VEGF will be reduced, and that your macular edema will respond to your anti-VEGF treatment. If you find out there is macular ischemia on fundus fluorescein angiography, actually there is no treatment for the ischemia. You cannot treat ischemia. Then again, there is some controversy. Some people are saying that if the foveal avascular zone is enlarged, or if it's irregular, and still if you inject anti-VEGF in this patient, it's going the foveal avascular zone to be further enlarged. But on the other side, some people are saying that even if there is some type of or some amount of macular ischemia, still if you give anti-VEGF, and the associated edema will be resolved, and the vision that is reduced because of the edema, actually that can be recovered. So there are two school of thoughts in this region, but ideally there is no treatment for the macular ischemia, and in such patient the prognosis is guarded, and we need to explain it to the patient that whatever we do, actually the vision is not going to be recovered in cases of macular ischemia. Sometime again, if there is no response to the anti-VEGF, we have to go for the wide field angiography, and the hotspots are there, which are the new vessels, and it means it's a proliferative disease. And for the treatment for the proliferative disease is we have to go for the panretinal photocoagulation. OCT biomarkers are important in the treatment of the macular edema. One is the central subfoveal thickness, because previously it was postulated that actually the prognosis depends on the amount of the macular edema. Like a patient with the 700 microns will be having bad prognosis, bad prognostic patient in comparison to a patient who is having 400 microns of the macular edema. So the lesser the amount of macular edema, the better will be the prognosis. The more the macular edema the patient is having, the worse will be the prognosis. But actually now we are know that actually it's not the case. And whatever the amount of macular edema is, if the retinal layers are well differentiated than normal, whatever the amount of macular edema, if you treat this type of macular edema, the vision is going to recover. Another important thing to keep in mind is drill, that is disorganization of the retinal inner layer. You can see here the retinal layers are well differentiated from each other, whereas on the other side there is poorly differentiated retinal layers. So in such patients, if the macular edema is there and if you treat the macular edema will resolve, but actually these are again bad prognostic patients. The prognosis is bad in these patients. So we need to explain it to the patient if there is drill on the macular OCT. Hyperreflective foci, usually we see such type of patients. There are hyperreflective foci within the retinal layers, and there are various theories about these hyperreflective foci. Some people are saying that it's actually the exudates that has gone down. Some people are saying that these are the secretions of the photoreceptor layer. And one theory about this is that actually it's the inflammatory and origin, these hyperreflective foci. And the point that's going in favor of this inflammation is actually these patients respond very nicely to steroids in comparison to the anti-VEGF. So patients with a hyperreflective foci, if it's there, then must think about the use of steroids in these patients, and they respond nicely to steroids. Then various steroids we can give for the macular edema, but actually the first line treatment is the anti-VEGF. Then it's the second line of treatment. You can use triamcinolone acetonide. It is not approved for the treatment of the diabetic macular edema, but in developing countries it is used. Subtenon injections can be given, suprachoroidal injections are given, intravitreal injections are given, but actually all types of steroids are associated with the two main complications, that is the rise in intraocular pressure, glaucoma, and the cataract formation. Dexamethasone implant was approved by the FDA after a MEAT study, and actually it works for about 6 months. And the first up to 90 days, its action is increasing. It reaches to the peak level by the 90 days, and then coming down. And usually the effect is not there after 6 months. So it need to be re-injected again if the patient again develop macular edema. Fluocinolone acetonide is actually, it got approval after a famed study, that is fluocinolone acetonide and macular edema. And actually it's a long acting drug, and its action will be there for up to 36 weeks. So it's a long acting drug. And again, with all these steroids, actually the risk, the complication that I already mentioned, that is the rise in intraocular pressure and the cataract formation, it will be there. But it can be given in patients who are not steroid responders, are the patient who are pseudophakic. So prochoroidal triamcinolone, again, it's nowadays quite a few years, since few years actually, it's a bit comparatively popular treatment options for various types of macular edema because of the increased vascularity of the choroid and the better availability of drug to the macular region if we use suprachoroidal injections. Combination therapy, sometime if one therapy is not working, you can combine the treatment, the therapy, that is the IV trial, and which the aflibercept is combined with the intravitreal, combined with the suprachoroidal triamcinolone acetonide, and which showed that the visual recovery is equal in both the groups, and which the aflibercept is given and the combination therapy is given, but the anatomical normalization of the macular region, that is better. And second, the this number of injections are required in the combination therapy. So again, it's a treatment option if the only anti-VEGF monotherapy is not working. And sometime partial vitrectomy is needed. Let's suppose the patient is having tractional element on the macular region. If there is epiretinal membrane over the macular region, then definitely the treatment is partial vitrectomy, through which we have to remove the vitreous, we need to remove the traction. And It is having increased oxygenation of the retina with partial vitrectomy. There will be decreased level of histamine, free radical, and VEGF release, because we know that the diabetic macular edema is multifactorial in origin. It's not only the VEGF, that is the vascular endothelial growth factor, which is responsible for the macular edema. There are so many other factors, like in the vitreous of the diabetic patients, the inflammatory mediators are very much abundant. The interleukins, cytokines, inflammatory mediators are abundant in the vitreous of the diabetic patient. So if we remove, and that's the reason that if the anti-VEGF is not working, then we have to shift to the steroids. That is having a potent anti-inflammatory effect. If the anti-VEGF is not working in your patient, then think about it that the VEGF might not be the predominant factor in this type of macular edema. It might be the inflammatory mediator which is responsible for this type of macular edema, because you have given so many anti-VEGF injections. So better to think about the steroids in such patients. Then it's, and again, a controversial thing that in the diabetic vitrectomy, whether we need to peel the ILM or not to peel the ILM. And study have shown that whether if you peel or if you do not peel, actually the visual outcomes remains the same. Then some association of the diabetic macular edema. Let's suppose the patient is having cataract associated with the diabetic macular edema as well. So what you need to do, the protocol P and Q of drcr.net, actually it showed then protocol P that NPDR patient developed diabetic macular edema after cataract surgery, whereas protocol Q showed that already patients who are having diabetic macular edema, it worsened after cataract surgery. The reason for this is quite obvious, like any type of, as I already mentioned, that diabetic macular edema is multifactorial in origin. Along with the VEGF, the inflammatory mediators are also responsible for the macular edema and retinopathy progression. So if the patient, if we, cataract is definitely intraocular surgery. If we are, and with the cataract surgery, actually we are inducing inflammation within the eye, and that inflammation will further increase the macular edema. So in order to treat such type of patients, if the view is there, and previously we used to do focal laser for the macular edema before going for the phacoemulsification, but now the anti-VEGF are available, so better to inject anti-VEGF and these patients and then go for the phacoemulsification. So the anti-VEGF will suppress the macular edema and inflammatory mediators and VEGF for that specific duration of time. Then if the patient is having diabetic macular edema along with the PDR, and if you want to go for the pain-retinal photocoagulation as well, so better visual acuity and macular thickness was observed after 2 injections of anti-VEGF and eyes undergoing to PRP, that is pain-retinal photocoagulation. And these are the recommendations of the protocol J of drcr.net. Whenever there is macular edema and there is proliferation as well, there is the patient is having the PDR. So first, always think that we have to treat the macular edema followed by the proliferation. For the macular edema, previously when the individual were not there, they used to go for the focal laser followed by the pan-retinal photocoagulation. And if their disease is severe, then at that time they're actually doing these both laser, that is the focal laser and pan-retinal photocoagulation at the same time. But now anti-VEGF are available. You can give anti-VEGF. With anti-VEGF, you can have time for the retinopathy regression along with the macular edema. So anti-VEGF followed by the PRP. If there is bilateral macular edema, actually so many actually unwanted incidents happen that the patients develop endophthalmitis, because endophthalmitis is a risk with the anti-VEGF anywhere. So if you are injecting in both the eyes, you are posing the patient with the risk of endophthalmitis in both eyes, and it has happened so many times. So the patient education is very much important. Better not to inject at the same time, and we need to educate the patient about the anti-VEGF injection. These are the risk factors associated with this, and each eye should be treated separately, completely separately. Scrubbing and everything should be separate from that of the other eye. Diabetic macular edema and pregnancy, actually the anti-VEGF are all type of anti-VEGF are having teratogenic effects, and it should not be given. Better to avoid it in pregnancy. But what are the other options available? That is the lasers and steroids. Again, if the patient is young, the steroids will be associated with the mentioned complication, that is the cataract formation and the rise in intraocular pressure. But the lasers can be done, and if the time is there, let's wait for the, if the macular edema is not that much severe for the pregnancy, then after pregnancy we can treat these patients with the anti-VEGF. But during pregnancy, specifically in the first trimester of pregnancy, anti-VEGF should not be given and it should be avoided. And if the treatment is needed, the available treatment are the lasers and steroids, because the anti-VEGF and the class 3 are category 3 drugs and pregnancy, so they're not safe. What is the way forward of treatment or combating with the diabetic retinopathy? Actually, we need to make awareness that is within the general population, community-based, hospital-based, and also awareness among the physicians, endocrinologists. As I already mentioned, that very few ophthalmologists or physicians used to refer their patients for the retinopathy screening until and unless the patient felt itself that there is a drop in the visual acuity and we have to consult the ophthalmologist. Another thing is the ophthalmologists need to be trained in the diabetic retinopathy treatment, that specific level of disease or this type of severe disease will need this specific type of treatment, and how to grade diabetic retinopathy. Then the protocol need to be devised, because the protocols like in the developing country protocol will not make that of the developed countries. Like bevacizumab, you cannot inject bevacizumab in developed countries, but it can be injected in the developing countries because there is no other way out. The patients cannot afford, they have to buy it for themselves. They cannot afford the expensive medications. So protocol need to be devised at national and regional levels. Like the protocol as showed that the anti-VEGF are better than PRP in the first 2 years, but actually for our population, I think the PRP will be better because the patient cannot afford the anti-VEGF. So if the patient has the PDR, we have to go for the PRP. So that's why we have to make our own protocols depending on the regional and the national levels, and we need to individualize our patients, that this patient will need this type of therapy and another patient will need another type of therapy. Again, it depends on the socioeconomic status of the patient, the follow-up of the patient. So again, you can individualize your patients. Diabetic retinopathy clinics need to be established. It doesn't need a very high-tech equipments, just need a slit lamp and a trained person, a retinal specialist. At such time, even the patients will be feeling very good that this is the diabetic retinopathy clinic. I have to come over here and I will get treatment from here if anything happens. And that then the Lysan will be there and the patient will be coming properly for the screening and also for the follow-up. Fundus photography that is done should be done at least in the teaching hospital. It should be introduced, and the larger are the referral hospitals. And only need, as I already mentioned, that the optometrist need to be trained, and he need to be trained in the grading of the diabetic retinopathy. And then actually, if the patient needs retinal specialist opinion, then the patient can be referred to the specialist. Otherwise, the patients should be kept on follow-up. Diabetic retinopathy treatment is not possible without proper counseling because it's a lifelong disease. It needs lifelong follow-up. Again, depending on the severity, the treatment need to be repeated again, again, and again, whether it's anti-VEGF, it's steroids, it's the laser that have to be augmented with the passage of time. So proper counseling is very much important, and making the patient understand about their disease, the severity of the disease and the progression of the disease, and what the patient expectation should be after retinal surgeries or after injections. So counseling is needed in the diabetic patients as well. The take home message is actually, first of all, we need to control the risk factors. If the risk factors are not controlled, if we are treating our patients, the patient glycemic control is not there, hyperlipidemia is there, the other risk factors associated with the hypertension and all these things, if it's there, then the patient is not going to respond to your treatment. The first thing you need to educate the patient about is to control the risk factor for the progression of the disease. First, do a baseline OCT to detect there is macular edema or not, and whether it's center involving or non-center involving. If it's center involving DME, give anti-VEGF. If it's non-center involving, go for the focal laser based on the fundus fluorescein angiography. If you are going for the focal laser, you have given 3 injections. Again, repeat OCT, and because OCT is done for the monitoring, for the quantification of the macular edema, and also for the monitoring and the response of your treatment. After 3 injection, again repeat the OCT and look that whether your patient has responded to your treatment or not. If the patient responded to your treatment, still there is some macular edema, the vision is improving, continue with those anti-VEGF. If the patient has not responded to your treatment, the macular edema is not reduced, or the vision is still deteriorating, or it's stable. If there is no improvement, check for the macular or peripheral ischemia or traction. And for that, we need to go for the wide field angiography to check for the peripheral ischemia, to check for the macular ischemia. If there is no macular ischemia, means everything is normal, the macula is well perfused, then change the brand of the anti-VEGF. If you are giving the bevacizumab, change to the ranibizumab. If you are giving the ranibizumab, changes to the aflibercept. If you are giving aflibercept, change to the faricimab. Just change the molecule of the anti-VEGF and look at whether it's working or not. Again, give 3 injections. If again, go for the OCT, repeat and check that whether now this treatment has worked or not, whether your patient responded to this treatment or not. If still there is no improvement, then it means that the vascular endothelial growth factor is not the main culprit and this type of diabetic macular edema. As I already mentioned, that diabetic macular edema is multifactorial in origin. It means that we have to shift to the second line drugs, that is the steroids, combination therapy of anti-VEGF plus steroids, suprachoroidal injections. Sometime if there is peripheral ischemia, we have to go for the PRP, and with that sometime the macular edema respond, and the pars plana vitrectomy that I already mentioned. So it's going to be hard, but hard doesn't mean impossible. So it's possible that we can treat these patients and we can overcome these problems and these challenges. Thank you very much. And I will go to the MCQs. Uh, the first one is a 52 years old patient with a history, uh, patient for the, I will stop share my screen over here. So a 52 years old diabetic patient from the last 8 years presented with the visual acuity of 6.9 in the left eye. What is the best treatment option in this patient, the patient with the macular edema? That is whether we have to go for the anti-VEGF injections, whether the patient need combination of anti-VEGF plus focal laser. Focal laser is needed or intravitreal steroids implants are needed for this patient. So anti-VEGF injections, because I already mentioned that the patient is having a vision of 6.9, because the anti-VEGF are indicated for a vision of 6.9 or worse. So anti-VEGF is the first line of treatment. Combination is not needed in such patients because first you have to try only the monotherapy that with anti-VEGF. Focal laser not for the center involving macular edema, and steroids implants are the second line of therapy. So first line is the anti-VEGF injections. So question number two, a 48 years old diabetic patient presented for routine checkup for the diabetic retinopathy. His visual acuity and the left eye was 6 by 6, that is 20 by 20. OCT shows center involving diabetic macular edema. Which of the following is the best treatment option for this patient? Anti-VEGF injections, focal laser, observation, steroid implants. So about 24% of the audience actually responded that anti-VEGF treatment is needed, focal laser about 9%, and 67% correctly pointed out that observation is needed. And basically that is what I mentioned, that it's the protocol V, that if the vision is 6 by 6, 6 by 6 is not an indication for the anti-VEGF therapy, even if the OCT shows the macular edema, because as I already mentioned that in protocol V, actually they injected anti-VEGF to a patient with 6 by 6, and some patient they observed, and they came to the conclusion after 2 years that the visual outcome at the end is the same in both type, whether you treat these patients or you observe. So the recommendation is, if the patient is having 6 by 6 vision without with macular edema, actually we have to observe these patients. Third question is, a 38 years old diabetic patient presented with decreased vision in her left eye. She is pregnant with 12 weeks period of gestation. It means she's in the first trimester. Her OCT showed central macular thickness of 343 microns with central involving diabetic macular edema. What will be the most appropriate treatment option in this patient for treating her macular edema? We have to go for the anti-VEGF injection, that is the aflibercept. Ranibizumab is more safe. We have to go for the observation or focal laser. So, 10% of the patient responded that intravitreal aflibercept can be given, ranibizumab can be given by 11%, observation 38%, and focal laser 42%. Actually, if you look at the amount of macular edema, that is 4343 microns is the amount of the macular edema. So, we have to go for the focal laser. As I already mentioned, the anti-VEGF are not indicated are because it's in the class 3 drugs regarding the safety and pregnancy. It is having teratogenic effects. Actually, the ranibizumab is having low potential for teratogenicity, but said it should be avoided, the anti-VEGF. So the better is to go for the focal laser in these patients. There are a few other questions as well. One is how to manage the macular edema with epiretinal membrane. The answer is quite obvious. The epiretinal membrane, we have to remove the epiretinal membrane because whenever the traction is there, if there is ERM formation, that is the epiretinal membrane, the treatment is according to the cause and associated. You can give anti-VEGF, but actually your anti-VEGF is not going to work because the epiretinal membrane will be having their foot plates and it is attached at different points to the surface of the retina. So you have to remove the epiretinal membrane with the removal of the vitreous. Again, actually the that mean we are going for the pars plana vitrectomy and remove for the treatment of diabetic macular edema. Again, the vitreous will be removed, the inflammatory mediator will not be there, and such patient will respond to your treatment. I have to look for some other questions as well. That's a very good question that if the patient is having fibrovascular membrane developed and the patient's before that the patient received 2 injections of VEGF, so what will be the risk of vitreous detachment? I think they want to ask about the retinal detachment. But whenever there is fibrous tissue, actually fibrous tissue, why it is formed? It is an advanced stage of the diabetic retinopathy, means the patient has developed proliferation. Then there is regression of the proliferation either due to injections or self-regression is there, and then the vascular tissue changes into the fibrous tissues. The glial cell proliferation is there, and whenever these fibrous tissue actually on one side it is attached with the surface of the retina, on the other side it grows into the vitreous as well, and whenever there is movement of the vitreous there is traction on the retina and it will lead to the tractional retinal detachment. And such patient actually there is no role of anti-VEGF. Again, it depends if it's the traction or fibrovascular component. If it's very much in the periphery, again you can give anti-VEGF injection, but if it's threatening or involving the macular region, anti-VEGF are not indicated because anti-VEGF will further aggravate your issue, the problem. Anti-VEGF can be given, but if you plan for the pars plana vitrectomy, and it can be given because different surgeons are having their different opinions, and it can be given from 1 day up to 7 days. You can inject these patients before going for the pars plana vitrectomy. There is another question. If the vision returned to 6 by 6, 20 by 20, and the macular thickness is again normal, then you will still inject or not. Then there are two protocols. One is the treat and extend, and one is the PRN. Actually, in some studies, they have gone for the injection. They increases the duration of injection. Like instead of giving monthly injection, if the macula is normal, the vision come to the normal level, then if you are giving monthly injection, shift to 2 monthly injection. If it's still working, shift to 3 monthly, 4 monthly injection. And the second protocol is once everything comes to normal, ask the patient to control the risk factors for the progression of the disease. And then if there is the visual drop or if the edema reoccur, again, you have to go to your first point and restart the patient with the anti-VEGF injections. Yes, exactly. The another question is if centrally involving macular edema with a vision of 20 by 20, I will follow up. Definitely, we have to follow up, and that's the recommendation of the protocol B as well. If 6 by 9, it will need treatment. Yes, definitely. 699 are worse, then the patient will need treatment. Uh, Another question is that should I treat non-center involving edema and should I use laser? Exactly. But keep in mind that the laser should be based on the finding of your fundus fluorescein angiography. You have to apply the laser only to the leaking microaneurysms. Sometimes most of the microaneurysm are there. It's visible, but it's not leaking. Actually, those microaneurysm who do not leak actually do not need treatment. We have to treat only the leaky microaneurysm, and only those leaky microaneurysm are responsible for the development of the macular edema. NPDR and diabetic macular edema. Uh, how minimum should be the duration of separation for the laser after injection? Actually, it depends on the amount or the duration or the duration of action of the injection. Usually, after 4 weeks, the duration, the uh, drug effect on the eye is not there. So better even and the cataract surgery if the patient is going for the phacoemulsification and if you are planning the panretinal photocoagulation. So it should be within that 1 month period in which you have injected. Again, it's a very good question that do you think that there is any role of artificial intelligence used in diagnostics of diabetic retinopathy and monitoring of diabetic retinopathy prognosis? It's very nice. Actually, there are so many artificial intelligence tools for the grading of diabetic retinopathy that has been approved by the FDA even. And the sensitivity of those, the accuracy of those artificial intelligence tool is more than 90%. Even some are having more than 97 to 98% with accuracy they can grade your diabetic retinopathy. So actually, again, if the main part, the human resource is not there, the retinal specialist is not there, you can take the help of these artificial tools. But again, we have to sensitize those who are in the power corridor that these things should be implemented so that we can screen and we can detect the retinopathy at early stages. Then the burden of the disease will be less. Otherwise, it's a head-on collision that we will be going face great difficulties in future in terms of treating the diabetic retinopathy patients. uh, no resistant diabetic macular edema, non-responsive diabetic macular edema after anti-VEGF. Actually, we used to give 3 anti-VEGF injections. If the patient is not responding to the treatment, the macular edema is aggravating, the visual loss is increasing, then actually it's non-responding type of macular edema. And then usually we are going for the fundus fluid seen in geography. Again, what I mentioned in my presentations that we have to look for the non-perfused region, the macular ischemia, and then we have to shift from one treatment plan to another one. What's your experience of the Avastin mixed with the dexamethasone? I have never used it, but I have used Avastin plus suprachoroidal triamcinolone, and it works very nicely. When can you stop the anti-VEGF injection? Again, coming to the same point that you can stop your anti-VEGF injections. Let's suppose if you are giving anti-VEGF injections for a patient who is having a visual acuity of 618 and the amount of macular edema, let's suppose 320, and you have given 3 injections, 4 injections, monthly injection to that patient, the vision is recovered, the visions come to the normal level, and also the edema is not there. And it's you can stop the anti-VEGF at that point. Now, there is another point. Another patient, let's suppose you are injecting the anti-VEGF in that patient, and let's suppose the visions come to a level of 20/40, and the vision is not further improving. There is some macular edema, but again, that is not responding to your treatment. So at least 2 injections you have given, the vision becomes stable at that point. The macular edema becomes stable at that point after 2 injections or at 2 visits. Again, it's an indication that you can stop your anti-VEGF injections. Now, again, you have to stop and see. Now, again, if the vision is deteriorating, if the vision is going again to 6/18, 6/24, or the macular edema is increasing, again, it's an indication to restart your anti-VEGF injections. Actually, the problem is with the diabetic patients because it's a lifelong disease. And again, we have to take care of the risk factors. Once you control the disease, it's not like this that the patient will become stable. For the patient might be stable for quite some time, but actually there will be some ups and downs because when the patient is developing diabetic retinopathy, actually they have lived with so many years with diabetes. And actually, it's very difficult to control the diabetic level at that stage. Focal laser parameter, actually, the spot size should be less than 50 microns, and the power should be usually from, we are using it about 70, 80, 90, but it should not be more than 150 millijoule. And secondly, and focal laser, you should not get a prominent reaction. Actually, you just have in your imagination that I have hit at this area. It should be as less as possible because of the increase and the laser scar with the passage of time, and definitely that you are applying it to the macular region. So we have to take care of that. We have to apply very gentle laser to the macular region. Definition of central and volume macular edema, that is by the ETDRS chart, the central one, the central circle, that is basically 1000 micron, any edema, and that 1000 micron region is basically the central and volume diabetic macular edema. Outside that is actually the non-central volume diabetic macular edema. The chronic CME are the non-responding CME, as I already mentioned. After 3 anti-VEGF injection, the patient is not responding to your treatment. It means the patient is having a refractive DME, and you can change your treatment protocol from one to shift from anti-VEGF to steroids or to laser. What is the critical thickness after which I can say it's edema? Actually, again, it depends on the machine, that on which machine you have performed the OCT. Actually, some machine are calculating the depth actually starting from the RP layer up to the internal limiting membrane. Some are excluding the RP, but actually roundabout and most of the studies they're taking it to 50 microns to be normal. Paco into Jeff in the same setting. Yes, exactly. Some people are doing this. Some people even doing vitrectomy followed by the anti-VEGF injections. It's also a treatment options. Suprachoroidal injection is better than subtenon. In my experience, I think suprachoroidal is much better than the subtenon injection, because subtenon you are giving in the subtenon space, whereas the suprachoroidal actually you are going in the suprachoroidal space. Actually, that's a highly vascular structure. The drug availability to the macular region is tremendous in comparison with the subtenon space. But uh, actually, the injection, most of the people are not used to inject in the suprachoroidal region, but that's quite easy. Suprachoroidal versus intravitreal, again, it depends. Intravitreal, there's high risk of these complications, and it is said that in comparison to the intravitreal triamcinolone, actually, with the suprachoroidal, these complications are comparatively less. Difference between PPV and photocoagulation. Again, the indication are different for both of these. If the patient is having traction component, and if you go for the panretinal photocoagulation, but keep in mind one thing, that like if you are saying that if there is fibrovascular component, FVP is there, fibrovascular proliferation is there, and when we are saying that while injecting into VGF, it will increase the traction. Exactly in the similar way, your photocoagulation will also increase the traction in such patients. It's not like this, that photocoagulation, but with the photocoagulation, fibrosis scars are formed, the macular become the strength of the macula is increased. But actually, the photocoagulation still, and that's the reason that we are going away from the proliferation, the area of the proliferation. But actually, the indication for the PPV and PRP are different. If you are thinking that it's a surgical case, then deal it surgically. And if you are thinking that we can apply laser, and with that the disease will reverse, and the disease will be quiet, then you can go for the photocoagulation. Yes, exactly. Anti-VEGF and steroid can be given at the same time. Any case that I have damaged the macula of the patient, I don't remember. I don't think so. I have done it so far. Actually, suprachoroidal injections are available. How to give suprachoroidal injection, and it's exactly the same way, that is 4 millimeter from the limbal area, and the depth is not penetrating the whole thickness of the reaching up to the vitreous cavity and in suprachoroidal space, because you cannot penetrate more than that. The second thing is you can make your own injections as well from the insulin syringe. Actually, the remaining part, only the tip, the bevel should be visible, and the remaining part is covered with the IV cannula. And with that, because only the tip will penetrate into the sclera, reaching the suprachoroidal space, and you can inject the suprachoroidal triamcinolone. But I am using the already the syringes that is used for the suprachoroidal injections. So that's all from my side, I think. So thank you very much, all the audience, for listening to me patiently. And it's a very important topic, the diabetic macular edema. And actually, the population of diabetes is increasing, and we have to take care of this. Otherwise, most of our health resources will be going towards the treating just diabetic retinopathy and the complication of the diabetic retinopathy. So thank you very much again. Thank you very much for listening to me.